Hello everyone, welcome to another NP Academy lecture. Today we will talk about Otitis Externa, or in the other word people call it swimmer's ears. So let's talk about Otitis Externa. We will discuss what is Otitis Externa, what causes it, what are some of the risk factors who get the Otitis Externa, how the patient will present to you, so what are the signs and symptoms, how you will diagnose them, diagnosis, how you will treat them, treatment, and what are some of the consequences of Otitis Externa. So let's look into the Otitis Externa first. To understand the Otitis Externa, let's draw the structure of ear. So this is your ear. As you know, ear has a three part of it. Your external ear, that composed of your auricle or pinna, and then there's a structure of this pinna here. This is called tragus. There's the importance of tragus in the diagnosis. And you have an ear canal, and then your middle ear start with the tympanic membrane. This is your tympanic membrane. So until here is your external ear. Then in the middle ear you have three small little ear ossicles, and those are your small little bone called malleolus incus. So this is your malleolus, this is your incus, and let's just keep this as the stapes. This is your stapes. These ear ossicles basically transmit the sounds from tympanic membrane to internal ear. So until here is your middle ear, and then at the end you have a internal ear that has a cochlea and the semicircular canal that manages the hearing and balance. So this is your internal ear. Well, Otitis Externa, as the name suggests itself, is the inflammation of external ear, and most commonly it's the inflammation of ear canal. And this inflammation often leads to the swelling and edema. So Otitis Externa is the inflammation of external ear. And there is a spectrum to it. In the case of mild condition, you have a mild erythema and edema to the canal. In the severe situation, you have so much of edema that ear canal can get almost swollen shut. And sometimes the inflammation can go all the way to the auricle and on the tympanic membrane. But most commonly though, it's ear canal. Now this inflammation is caused by bacteria. It's a bacterial infection. And there are two most common bacteria that cause this infection, and you need to know the name of these two bacteria, and these are your Pseudomonas and Staphylococcus aureus. The other word people call it staph. So the Staphylococcus aureus and Pseudomonas are the two most common bacteria that cause the Otitis Externa. Okay, let's look into the risk factors. Who gets the Otitis Externa? Risk factors. One of the most common risk factor is the moisture in the ear canal. Moisture in the ear canal. And most commonly this is brought upon by swimming. That's why they call it swimmer's ear. And so it's true that Otitis Externa is more common in the month of summer, usually in the August when people are swimming around. It's also very common among school-age children when they are out on the break and they swim. If you are studying for the NP board, they love to ask this question. They will ask you that kids come to you with the ear pain and they're trying to know what it is. And they will give you some hint that this kids is on the school break, this is the month of summer, they have been swimming a lot, and what do you think? And this is basically asking you about the Otitis Externa. Well, swimming is not the only thing that can cause it. Some of the other risk factor is the people who take long shower or the long bath. They are also at a higher risk for accumulating moisture in the ear canal, and that can contribute to otitis externa. Okay. Other risk factor is any injury to ear canal. So people who put a lot of Q-tip in the ear, they can cause it, or the people who use the hearing aid. Sometimes the hearing aid can contribute to the otitis externa, or people who use the earphone a lot, that can also contribute to otitis externa. The other one is the wax removal. People who remove their wax all the time. Believe it or not, this wax has some protective properties to it. One of the key feature of the ear wax that this is happen to be acidic in nature, and this acidity actually decreases the growth of bacteria and growth of fungi. And most importantly, this acidity actually decreases the growth of these two common bacteria, the Pseudomonas and Staphylococcus aureus. So the people who like to remove their earwax all the time, they are at higher risk for getting the otitis externa. Okay. Well, what are some of the signs and symptoms? How the patient will present to you? Sign and symptoms. Some of the most classic sign and symptom for otitis externa is this: itching. Let's say my spelling is here. Itching, pain, and decrease in hearing. These three are the most classic presentation of patient. They have a lot of itching, they have very intense pain, and they have usually decrease in hearing. Also, most commonly, this is unilateral. I mean, you can get in both ear, but usually in the one ear, and usually develop very within a course of like 24 to 48 hours. So quick onset. So these are some of the classic presentation of the patient. Okay, well, how you will diagnose them? So to make a diagnosis that is based on history, physical exam, and risk factors. If any patient who comes to you who has a history of swimming or any history of ear injury, and they have any of this complaint of ear itching, pain, decrease in hearing loss, and it's unilateral, then that help you a lot to make a diagnosis. But on the physical exam, what you will find is few things. First of all, if you look at the ear here, and when you push on the tragus, something called tragus tug, when you push on the tragus, patient will have a pain, and that is a classic finding for otitis externa. Or when you manipulate the pinna, they will have a tenderness in the ear. So pinna manipulation or tragus tug, when they have a pain in these two, then they will have a classic, that's a classic finding for otitis externa. Other thing is that when you will do the exam using the otoscope, you will see erythema and edema of ear canal. So these are some of the key findings on physical exam that will help you to diagnose otitis externa. So those are your tenderness on tragus tug, when you push on the tragus, or tenderness on pinna manipulation. In addition, you will have a ear canal erythema and edema. Based on this physical exam, along with the history and patient presentation, you will make a diagnosis of otitis externa. Okay, once you diagnose them, then comes down to treatment, how you will treat them. So treatment, there are few aspects of treatment. You're going to treat the pain, and you will treat the inflammation, and you will treat the infection, and you will cover Pseudomonas and staph. Well, pain you will treat with NSAID, mainly because otitis externa is the inflammatory process. NSAIDs are anti-inflammatory, so it works great. You can use as simple as Motrin or as strong as Toradol. Inflammation you will treat with a steroid, and infection you will treat with antibiotic. You can use only antibiotic to treat it. However, it's very important to use both steroids and antibiotic. I have seen it that when you prescribe them only antibiotic, it doesn't help that much. But even the moment you add the steroid, it really helps tremendously. So always use both. Other key things about the treatment is that you want to use topical preparation. That means ear drop. Mainly because the infection is in the ear canal, you put the medicine in the ear canal and it works like magic. PO medicine not really good for this, mainly because when you take the tablet PO by mouth, this does not have a good penetration to ear canal, as well as you expose the patient to the systemic side effects. So topical is the way to go. Now, the best drug to treat the otitis externa is your Ciprodex. Ciprodex. Basically, this is your ciprofloxacin, fluoroquinolone, that cover both a staph and the pseudomonas, and the strength is 0.3%. And this is your dexamethasone, is your steroid, 0.1%. And the dosing regimen is whether it's adult or peds, the same. You will use 4 drops BID twice a day for 7 days. It works like magic. One thing to know about it that when you are prescribing the antibiotic, you need to know about the tympanic membrane. Is the tympanic membrane intact or if it's ruptured? Or does the patient have any tympanostomy tube? Just remember, if you didn't get to look at the tympanic membrane, in that case you cannot rule it out that tympanic membrane is intact, mainly because you did not see them. And it's very likely that you cannot get to have a good look on the tympanic membrane, mainly because there's so much of swelling going on and there's so much of pain. So it's very hard to look at the tympanic membrane. So if your tympanic membrane is ruptured, then you have only very few options, and one of the best options is the Ciprodex. Ciprodex is the only drug that is approved by FDA that is safe to be given when the tympanic membrane is ruptured. So if you don't get to look at the tympanic membrane, that means you don't know if it's ruptured or not, Ciprodex is a good drug, whether tympanic membrane is intact or ruptured. It's a wonderful drug. It always works. Well, one of the problems with the Ciprodex is that it's very expensive and lot of time the insurance does not cover it. So in that case, your alternative is ofloxacin. Basically, this is your ciprofloxacin for eyes, ophthalmic solution. The strength is the same, 0.3%. The dosing regimen is little bit different. In adult, we use 10 drops, and in peds we use 5 drops, and only once a day. And then in addition to that, you have to use the steroids. Very important to add the steroid. So steroid here will be your dexamethasone solution, and usually it's 0.1%. And the dosing is whether it's adult or peds is the same. You will use 4 drops BID. And just like Ciprodex, this combination drug and the ofloxacin is also safe if it's a ruptured tympanic membrane. So it's really safe medicine. And I usually use either Ciprodex or this combination. This is my go-to drug. It always works. It has never failed me. Well, the other option is something called Cortosporin. Cortosporin otic. This is your combination drug that has 2 different antibiotic and it has a steroid. So your antibiotic in this one is your neomycin, that is your aminoglycosides that cover your staph, and then you have polymyxin B. This cover your pseudomonas, and then you have a hydrocortisone steroid. And their dosing is this. In the case of adult, you use 4 drops, and in the case of peds, you will use 3 drops twice a day, BID. Well, the problem with the cortosporin is that your neomycin that happen to be aminoglycosides, this is autotoxic. So if you have a ruptured tympanic membrane, or if the patient has a tube in the ear, in this case, or if you did not get to look on the tympanic membrane, you don't know if the tympanic membrane is intact or not, in this case, do not use corticosporin. Do not use corticosporin because this is autotoxic. You will damage it. So the only time you will prescribe the corticosporin when you know for the fact the tympanic membrane is intact. This is key here. Okay, well, that's why I usually don't prescribe the corticosporin. Other problem with the corticosporin is that roughly 30% of the patient, 30% of the people will have a skin rash, something called chemical otitis to neomycin. So you prescribe them and they'll come to you after a couple of days that their symptoms are getting worse, mainly because they're getting the chemical otitis. Their ear canal is reacting to neomycin and making more rash. So because of this reason, I usually don't prescribe them, but every now and then I do. Okay, well, how about the duration? How long you want to treat? The duration is 7 days are your typical. However, sometimes you can use up to 14 days. However, in this case, you do want to reevaluate after 7 days to make sure what's going on. Okay, well, how about the wig placement? Every now and then you will have to put the wig. What is wig? What happened is that in the very severe situation where your tympanic where your ear canal is so swollen that is almost swollen shut. So in this situation, when you put the eardrop is not going anywhere, mainly because it's so swollen. So then you want to put the wick in the ear canal. Wick is nothing but the cellulose, and the way you put is that basically you just pull the pinna and put in the canal. The best way to do is that you need to know the trajectory of ear canal, and generally speaking, your ear canal has a little bit of 30-degree slope here, and ear canals are roughly around 2.5 centimeter length in the case of adult. So you look in the normal ear where there is no infection, get the trajectory, and then you pull the pinna and put the wick in the ear canal. I mean, the worst case scenario is one of the risk factor is that you can rupture the tympanic membrane if you really go too deep. So don't try to push too much inside, just put in the ear canal. And the idea is that when you put the eardrop onto the wick, say for example this is wick here, you put the eardrop, the wick will absorb the medicine and wick will get swollen. And then this ear canal will get exposed to the medicine. And as the inflammation will decrease, this wick will kind of fall off from the canal. However, once you put the wick in the ear canal, you need to make sure that patient get follow up, because the wick need to be replaced every 1 to 3 days if the inflammation is not decreasing. But the most likely, usually, once you put the wick, inflammation decrease and wicks fall off, and that's what you want. Okay. Well, how about the PO medicine? As I said earlier, you do not want to prescribe PO, mainly because lack of penetration to ear canal, and you increases the risk for systemic infection. However, if you do want to prescribe, then your medicine is here again, ciprofloxacin. And in the adult, you give them 500 milligram BID. In the peds, you give them 10 milligram per kilogram of body weight with the maximum 500 milligram per dose BID, and again for 7 to 14 days, but the 7 is your most common. Okay, well, what are some of the cause for the treatment failure? One of the most common cause for the treatment failure is your underdosing. Treatment failure. So what you have to educate the patient is that lay down on the side with the affected ear facing the ceiling, and then you put the ear drop and stay in that position for at least 3 to 5 minutes so that the medicine get absorbed in the ear canal. Another one is that you have to keep the ear canal dry. Keep the ear canal dry. So that means no swimming for at least 1 week until your symptoms are resolved. Also no bathing. You can take shower and you can put some cotton ball with some Vaseline on the ear canal to keep the ear canal dry. Also avoid using the earphone or the hearing aid until you have a good resolution of your symptom. So these are some of the things about the treatment. Okay, well, last topic is complication. So one of the most important complications that I want to discuss here is something called malignant or necrotizing otitis externa. This is really bad infection. The reason the malignant is not the accurate term. Actually, necrotizing is the more accurate term. So the malignant was given back in the day because the death rate because of this infection back in the day was roughly 50%. These days, now that we have a lot of antibiotic, the death rate is still somewhere between 20 to 30%. So it's really bad. So who get the malignant otitis externa? The majority of them, roughly somewhere between 70 to 90% of them are your diabetic people who has a diabetes, or the people who are immunosuppressed, like someone who has HIV or someone who are on the chemo drug. The way it works is that a lot of these patients, they get the otitis externa, and then this infection does not get better, but rather the infection goes and damages the bone. So malignant or necrotizing otitis externa is actually the osteomyelitis of your temporal bone, the bone that is surrounding the ear canal. This osteomyelitis of temporal bone. So this is really bad. These patients will be sick. On the physical exam, you will notice some purulent drainage. On the otoscope, sometimes you'll see the exposed bone. Sometimes you will see something called granulation tissue. This is really bad infection. These patients will need a septic workup. You need to draw the culture. You need to get the CT, and this is almost exclusively caused by Pseudomonas. So you have to get the big time antibiotic like Zosyn and all to cover the Pseudomonas. And you need to get the ENT consultation and infectious disease consultation. So the key here is that if you have a diabetic patient or if someone who is immunosuppressed and you are diagnosing them initially with otitis externa, you need to make sure that you have a close follow-up on them. On the other hand, if someone has this ear infection and that is not getting any better, a lot of times this patient, when they comes to you, they usually have ear infection and they get this ear drop and they are not getting any better, and then they come and they are really sick. So if they are not getting any better, and even if they do not have a diagnosis of diabetes, it's appropriate to check their blood sugar. A lot of time it will be really high. So as an NP, if you identify the malignant or necrotizing otitis externa and start this workup and make up a call to the ENT and infectious disease, I think you will do good, and from here they will take it. So I believe this is all about otitis externa. Hope you will find it useful. Thank you very much, and I will see you next time.